but really excited to see so many faces here today, especially because we moved the meeting a week early. So I'm going to pass it over to Adrienne. She's going to kick us off and give us a bit of a presentation on the work that she does and the work that is done in her organization. And then we will dive into some staff updates. So Adrienne, the floor is yours.
Thank you. Thank you for inviting me. Um, so I run the West Lebanon CTC, which stands for Comprehensive Treatment Program, which was formerly known as Habit OPCO, which is probably how you've heard of it, and affectionately called the Methadone Clinic. So we are a comprehensive treatment program that addresses opioid addiction. We're a daily dosing site, so that means that we are the highest level of care outside of inpatient treatment. So our folks come to us every single day and they receive either methadone or Suboxone, and then a combination of other services, which include individual counseling, group counseling, case management, nurse care coordination, and then we have a medical director and a physician assistant. So we have they're on site between the two of them 4 days a week. We are open 7 days a week. We run groups and individual counseling 6 days a week. So we only really close for a holiday, and that's sort of new to us. Up until I think last year, we never closed. Um, we have 386 patients right now who come to us daily. Um, in an ideal world, we're sort of the first stop because we are the highest level of care. We put eyes on people every single day. We have a really nice mix, I would say, of folks. 50% of our folks will be in recovery long term. They'll be here for a really long time. 25% of our folks do really well over the course of 6 years usually, and then they will taper out, or they will get take homes, which is when they can then come in either once a week or once every 2 weeks and get medication as if it's a prescription and take it with them. They still need to be doing clinical services with us. And then 25% of our folks are harm reduction folks. So that's, early in recovery, still using illicitly, contemplating what their recovery journey might look like. We are not a three strikes and you're out program. You do not have to be what is considered traditionally clean and sober to be here. Um, Anyone is welcome at any stage in their recovery. We do um, a lot of harm reduction stuff. So we have clean needles accessible from the HCV program. We are a Narcan distribution site. We try as much as we can to coordinate with other community resources. I get a lot of questions about sort of like what we look like on the inside because I think from the outside, our building is questionable. Um, it it's just sort of there. It's in the Staples Plaza. I grew up in the area. I never knew it was here. It's in the Staples Plaza next to where Pier 1 was, which is soon going to be Jersey Mike's, which we're all really excited for, and Vanessa's Salon, which is right next to Ziggy's Pizza. And our windows are tinted and mirrors so you can't see in. You guys are all welcome to come take a tour if ever you want. Inside, it's very much a medical facility. Um, so a day in the life of a patient looks like coming in, and we have a kiosk at the front door, and you'll type in your patient identification number, and that will tell you where you need to go for the day. So that will let you know if you need to go to the front desk and sign forms with the admin team, if you have an appointment and you need to check in for that, if you have a urine screen, or if you just get to dose that day if you don't have an appointment or a group. And then you'll either check in and go to your group or see your counselor, or you'll just get right into what we call the line. Um, and you'll go up to the dosing window, which is where Matt is. And you'll provide them with your personal identification, last five of social, date of birth, that kind of stuff. And then you'll get your medication, you'll have a conversation with the dosing nurse, and you might be done for the day. So you might be on site 5 minutes, you might be here an hour and a half, depending on what that looks like for that day. And it's scheduled so everyone knows. We offer a combination of in-person and telehealth at this point in time. COVID really allowed us to expand the telehealth program so that we could do that, and it's nice that we're still able to run that hybrid. So you can do individual sessions through telehealth. We have groups that run through telehealth, and that's been wonderful because with 386 people, we really need to be able to ensure that everyone is able to get their services. We do require 4 hours of clinical work a month on site. So it's basically a group a week. But I think there's been a misconception in the community that we're sort of a dose and go site that you can just come in, get medication, and leave with no other services. And I think maybe in the past that was the case. I've been here just about 5 years, and we've worked really hard to make sure that we're providing solid clinical care. We like to partner with local organizations. We have different tabling events throughout the month. We invite people to come in and hand out flyers or Narcan distribution or whatever it is. It really provides a warm handoff. We've had Planned Parenthood come in the past and the needle exchange. And if ever you need one of those services, you have sort of a friendly face and a nice way to make that connection. And yeah, do you guys have questions for me? No? Okay.
What is the age range? Oh, sorry. Should I raise my hand? Sorry.
Nope. Go ahead, Kim.
What age, how young do you treat?
18. So if we were to in the past, we've had phone calls about 16-year-olds. We could do it. We'd have to get a waiver from the state. But for the most part, our patients are 18, and I think our oldest is early 70s.
And I'm guessing you do Suboxone too, right? It's not
We
just.
do.
Okay.
Yep.
Thanks.
So primarily we do methadone. We do have a Suboxone program. Suboxone is a little tougher because there are so many providers who are waivered at this point. I think people don't want to come here every single day if they don't have to. That's double-edged. If they're ready for a spoke program, that's great. If they're not, that can be tricky. Ideally, we would love to have them come in to our program as a daily doser, and then we can spoke them out. That's really what we try to do because we know people don't want to come every day if they don't have to, and we don't want to make them if they don't need that level of care. So oftentimes we spoke them out to other programs. So we are a spoke in the New Hampshire Doorway Hub and Spoke program, but we are a hub for the Vermont Hub and Spoke program, just to make that really confusing. I get a lot of questions about safe use. I think people very much think that we're a safe use site, which we are not, which is why I always invite people to come in because sometimes when people come in, they'll say, oh, I guess I was expecting like beds or mattresses and like nurses injecting people with methadone. And so that's just not what we do. Suboxone is the films, unless you're allergic, and then we have tabs. And then methadone is just liquid methadone. That's dispensed out of pumps in the nursing station. One of the things that I try to do is connect with local organizations and break down stigma. I think there's still a lot of stigma around substance use disorders and especially methadone in particular. I remember when I first started, we had a dentist that a patient had gone to, and he needed, I think, 4 teeth extracted. And he'd been told that the dentist was refusing to give him Novocaine because he was on methadone. And was told, well, you're on so much methadone that I could cut your right leg off and you wouldn't feel it, which is just not true. And he's not on methadone as pain management, obviously. It's not what it's treating. So I think just there's been a lot of misinformation out there. So I really like to try to go out and break down those barriers, break down the stigma, and then provide education about what it is that we do, so that people are more informed and hopefully more recovery friendly. Matt, do you have anything to add?
Adrienne, I think that's remarkably thorough. The fact that you emphasized what I think is one of the most important things to me, and that's the fact that we as clinical people get to lay eyes on our folks daily. So we get to see whether they're trending up or trending down or increasingly at risk or struggling with something. And it makes a difference in their success because maybe we can nip things in the bud, or maybe we see them heading for a crash and we're able to plug them into other resources or just be a friendly face and they realize that they're not all alone in the struggle. So I don't think we can say enough about the advantages of this type of program, this outpatient yet daily intensive program with all of its features. So I think you really covered it well. And I really like the fact that a number of times you've invited people to come see it because I think seeing it is really believing it.
Adrienne, can you talk a little bit about what sort of barriers the people that come to the clinic face if you know, if they have to miss a day, or maybe they just drop off, you know, drop off your radar completely? You know, what sort of barriers are people facing?
Sure. I think transportation, honestly, is one of the biggest barriers. I think that's a challenge throughout both Vermont and New Hampshire. And part of it is lack of drivers. Part of it is, I mean, with COVID, if you were at all sick, nobody wanted you in their vehicle. So we try really hard to work with the local transportation companies as much as we can. Allison is our front desk person, and she basically has them on speed dial. Um, Insurance, I think, is another barrier, which sort of plays into transportation, because then we've got the, you know, we're talking about the Medicaid rides. But again, we work to get people connected with the right insurance. That can be tricky because sometimes they're talked into maybe a program that doesn't necessarily know that it isn't going to cover a daily dosing type of service. So we work really hard to help people opt into insurances that will provide the coverage that they need. And in the state of Vermont, we're lucky we have the uninsured pool. So if someone does not have insurance, we can put them in the uninsured pool, and basically we have a grant that will cover the cost of their treatment. So that's great. New Hampshire at this point in time doesn't have anything like that. So that's hard, but we work with people as far as payment plans. We never turn people away because they can't pay. That's just not, you know, that's just not who we are. So payment is a barrier. Again, the biggest barrier I really think at this point is transportation. Again, stigma, that's a barrier to some people, especially if they don't want people in their family to know that they're coming every day. I think there are, again, misconceptions about methadone. You know, when the treatment was initially rolled out by insurance companies in terms of payment, it was for a really finite period of time. I think it was 90 days. So there was this notion that after 90 days you don't need this anymore. And then that contributed to the stigma of, well, why are you still receiving these services? It's more than the allotted period of time. And so, you know, we really, like all of you, we view addiction as a disease. And if we compare that to a disease like, you know, high blood pressure, we're not going to put you on a medication that's going to correct that for 90 days and then say, well, clearly your body has learned how to do this on its own, so now you don't need the medication anymore, right? So there, you know, if there are other things that you're doing to change your lifestyle, then maybe you don't need that medication. But without those other pieces, just stopping the medication isn't going to work. So we battle that as a barrier, and we you know, we try to provide as much education as we can to folks when they come in. Time is a barrier. I think we have a wait list right now, which is like the first time ever that we've had a wait list. I think we have like 15 folks. It's not a long wait list, but I can't get anyone until next week. Usually we can get people in same or next day. But right now, with the weather turning colder, we have a huge population of homeless folks in our community who have suddenly realized that they need housing, and in order to have housing, they need to not be using and be working. So all of a sudden, there's this push to get into treatment. So we're managing that the best that we can. But that's an excellent question. Thank you.
Thank you. So my follow-up question to that is, as we all did our introductions, you hear, you've got a variety of people in different roles across the region. So I'm just curious, an ask to all of us, how can we, not only as the Altogether Coalition, but also people individually on their call in their individual roles, how can we support your organization and support the people in our community to try to reduce those barriers or try to address those areas? Sort of what's your call to action for us, so to speak,
Sure.
if you have one. Or
I mean, I would really love it if you guys would come visit. That would be like my I know that sounds like a weird call to action, but please reach out, set up a time, come see us, come bring information about your organizations, because so much of what we do is care coordination and case management. We provide health home services, which is basically case management, to connect folks to other organizations in the area. So if we have that information, we can refer people to you, and we can have more tools in terms of what's in our toolkit to be able to support people when something comes up. And then I would just say, if you want information about us, if you want some of our cards, if you want brochures, I'd be happy to get those out to you as a referral source. And again, I think a lot of it is stigma. We very much believe in all paths to recovery, and I think I do think there's still some walls around methadone. So just helping us break those down, and if this is not the right path for someone, that's totally fine. But if it is, or it's a starting point, great, let's do that. So yeah, please just reach out, be in touch, let me know, specifically what your programs do, how the services are offered, and I would love to be able to share that with folks.
Thank you. Anyone else have questions? Liz?
Yeah, so you mentioned a dentist, patient who had a bad experience at a dentist. Do you have dentists that have a good perspective on substance use disorders and like provide kind of a non-judgmental patient experience?
I don't know that I could say that we have anyone specific, and part of that is hard because we have to look mainly at the Medicaid accepting dental providers. There are some, they don't always accept patients. So they're kind of ever changing. So that's hard. The Mascoma Dental Clinic has been really great. When Red Logan was Red Logan, they were really amazing. And then there are some other private dentists that I've worked with. I used to run the Smiles program, which was an oral health screening program through the Ottaquiche Health Foundation. And so we connected with local dentists that way. And we actually saw there was a lot of crossover between the patients here. So if you're looking for a specific dentist, I could absolutely recommend a couple who are, in my opinion, recovery friendly. But it does shift and change depending on insurance and who's accepting new patients. And again, there's, especially with the Medicaid dentists, we found that there are a lot who don't want those patients in their waiting room. And that's hard.
Yeah, maybe I'll connect with you afterward for those specific, because we have patients at APD, and the question just kind of came up from our social worker. So I'd be curious. Thank you.
Awesome. Thanks, Adrienne. Does anyone else have any last questions for Adrienne?
I do.
Go ahead, Bob.
Adrienne, I know where you're located, and it's pretty low profile, and it doesn't seem that you don't draw attention to yourself, and I'm wondering if that's by design or if it's kind of a problem because people find it difficult to find you. And the second part is when you talk about transportation, I'm wondering if your location, if it was closer to like a hub for advanced transit, would make it easier for people to get there. I'm sure you have thought about that, and I just was curious.
Yeah, so the bus does come to BJ's. So advanced transit is pretty local, which is nice if folks live on the bus route. Because we are the closest hub in New Hampshire is Manchester, probably. And then the closest hub in Vermont, there's one in Rutland and one in Brattleboro. So we get folks from everywhere. A lot of people travel an hour and a half to get here, so they don't necessarily live on a transportation line, which is tricky. As far as the clinic, yes, we have definitely operated sort of under the radar, low profile for a really, really long time. And I would say it's not until the past year or so that we've started to come out of the shadows, maybe 2 years. And a lot of that has to do with, I think, the push from within of, but we're doing really good work. Why are we hiding what we're doing? So we don't necessarily want to draw a ton of attention to ourselves, I think, because of patient confidentiality, because we have so many folks coming through here every day, and we know why they're coming. So we don't necessarily want to out them, which has been a delicate balance. At the same time, we are, we've rebranded, we've changed our name. The inside of the clinic has been completely rebranded to match more company standards. So we are working on that. And then, we are very much a target in terms of local law enforcement. That's always a challenge that we have. I try really hard to work with the local PDs, but still every couple of months, we've just got officers circling the parking lot, running plates of everyone who's parked here. That's really hard. So the more under the radar we are, the less kind of negative attention we get, but then the less, light that we can shine on the work we do. So it's really a delicate dance that we just continue to reassess. Good
Okay,
question. Thank you.
thanks.
Anything?
one.
Yes,
Yeah,
Andrea.
I just have one more, and I apologize, Adrienne. I think I may have missed it, but can you, could somebody, just walk in off the street, or do they need to have a referral from somewhere? Like, how can they get established with services? Can you just remind me what that looks like?
Yeah, anyone can just walk in. So we do like evidence of an opioid use disorder for a year. If they don't come in with that diagnosis, that's okay. We can gather that information, usually from family members. But as long as they are actively using, we can't take someone who's using, methamphetamine, and not opiates, obviously. Sometimes folks will walk in and then we can't necessarily help them. But as long as they are actively using opiates, anyone can walk in and we can schedule them, usually next day. This week is weird, I think, because Thanksgiving's next week and we're closing for the holiday. But in general, we can get them in same or next day.
Great. Well, thank you, Adrienne. This was super informative. Very much appreciate you coming and giving us this this presentation and discussion on the amazing work that you all do. You're welcome to stay on for the remainder of the meeting, but also understand if you have other commitments and need to hop off, but very much appreciate your time today.
Thank you so much.
All right, so we are going to dive into staff updates now. We did not do staff updates at the last meeting because we dedicated the entirety of our last meeting to talk about sustainability for All Together. We did send out some staff updates with the minutes, but want to give our staff some time to talk about the work that we've got going on. So Andrew, I will start with you if you have updates you would like to share with our partners.
Sure. Thanks, Hillary. I just want to share, so Take Back Day was October 29th. Yeah, I think October 29th. So I just want to give a quick recap of that for everybody. So at this point, we have a total of about 518 pounds of medication that were collected for the Upper Valley region. And that is actually not including two of our police departments. We're still just waiting on totals for those. So it'll be a little bit, more. I'm not sure how much higher it'll be, but that's actually up by almost 200 pounds from this past April, up from last October. So that's really exciting to me. That says that all of our efforts in terms of our safe use, safe storage, safe disposal campaigns are working. The education we're putting out there, is effective. So we hope to see those numbers continue to climb. And I just want to point out that we actually had two really positive partnerships this October. So typically in the past, if you remember, on Take Back Day, we like to work with Lebanon PD to go to senior housing, senior apartments in the Lebanon area. And so this year we decided for this October, we wanted to do some sort of a community location, because those senior housing spots, we've closed it off to the public, mostly because of COVID. We didn't want people coming into the apartment complexes and things like that. So we really wanted to have a community site opened up, or location. So this year we partnered with Hannaford in West Lebanon. They allowed us to table for those 4 hours from 10 to 2 on Saturday, right in front of the entrance. So I had Lebanon PD with me. I was there tabling. And it was really, I don't necessarily have a way to measure the success. Just for me, from doing this for a number of years and a number of Take Back Days, I found it to be extremely successful. I had a lot of people come up and they were engaged in conversation, wanting to learn more about all together and the work that we do. I was able to give away 5 medication lock boxes for free. I'm sure I could have given away more, but that's all I brought with me because I had no clue sort of what to expect in terms of a turnout. Because we work closely with our emergency preparedness coordinator in the Upper Valley Regional Public Health Network, I was able to give away like 60 or so COVID tests. And so for me, it was a super effective thing. I will say the majority of people that came in, I did have the opportunity to ask how they heard about us, because again, this is the first time we partnered with Hannaford. And Bob, you'll be happy to know that nearly everybody said that they heard it on the radio. So Bob and I recorded, a generic Take Back Day event so that people would know that they can go to most local police stations, and then we recorded a separate one specific for the Hannaford Take Back Day event. So that's helpful for us to know that it's worth putting our money into advertising this through radio. So thanks, Bob, for that. And so the Hannaford, the store manager, he was pleased with the event, and he has invited us to come back every year. So as long as Lebanon PD is on board, I think this is something that I'd like to do annually, that every October we will do it, and I'll try to grow what we bring and offer to the community at this site. But just really pleased and happy with that partnership. And then Hillary and I, a couple days before the actual Take Back Day, we partnered with Hypertherm. I know Stacy's not here today. She wasn't able to make this meeting, but we partnered with Hypertherm and had Hanover PD with us. And we went to the Hanover location the Wednesday before. So that was really exciting. We didn't have as many people show up to drop off medications there, but again, it was, we were there and gave the associates the opportunity to safely dispose of their medication and look at some of the resources that Hillary and I brought. So overall, I'm really satisfied with the Take Back Day this past October, and hope to continue to expand upon it, every October. And then we will go back to the senior living locations for April. So we'll do that every April. We'll go there to give those folks an opportunity to not have to, deal with transportation or, leave their houses or anything like that. They'll be able to dispose of medications in April. And then, of course, as everybody hopefully knows, you can dispose of medications year round. You don't have to wait for Take Back Day. Many of our local police departments have 24/7 collection sites. And then the other thing that I'll share with that, Hillary, I hope I'm not stepping on anything that you're going to talk about, but we know that vaping is a huge issue across the Upper Valley right now. So just specifically with that, we asked 2 police departments if they would be willing to allow us to advertise that parents, adults, caregivers can dispose of vape devices during these Take Back Day events. And 2 of our police departments in a specific region that we are have a lot of concern about, they agreed to it, and they've also agreed to collect those vape devices year round, not just at Take Back Day. So we're really excited about that the PDs understand that this is a concern within our communities, and that they're allowing people to dispose of those. The only thing we ask is that we're asking people to make sure they have the battery removed out of the devices before they dispose of them. So I think that's it about Take Back Day. We are finally in contract with 2 of our consultants. So we are gearing up to start this kind of the hard launch of the Talk They Hear You campaign. So Bob, I'll be in contact to get some PSAs recorded and put a lot of time and effort into this campaign. So I apologize to all of you. You are going to be inundated with Talk They Hear You Facebook ads and radio ads and print ads and all of that jazz, but just super excited to get that campaign started. And I think that's it for me.
Great. Thank you, Andrea. Hannah, do you want to, I know you didn't have a chance to fully introduce yourself and the work that you're going to be doing with us. So I want to give you the opportunity now to tell folks about the work that you're going to be working on in both the Upper Valley and Greater Sullivan County.
Yeah, so currently the biggest thing I am working on is I'm helping out with Getting to Why. I'm not sure if that program was talked about here, but as a refresher, so hopefully in January we'll get YRBS data on how our schools are doing across New Hampshire. And we have 4 schools between Greater Sullivan and Upper Valley that have signed on with us, middle schools, to where we are going to recruit youth to look at the YRBS data in their schools and come up with projects to help support their communities. So currently in Upper Valley, Hillary is helping co-advise Indian River Middle, and I am going to help with Rivendell. So I'm figuring out a lot of the logistical pieces for that. And yeah, a lot of just youth substance misuse prevention work. I am, getting to meet still and connect with other partners around and see how I can help support all the schools around Upper Valley and Greater Sullivan with substance misuse prevention.
Great. Thank you, Hannah. And Maggie is also new to our staff. Maggie, I didn't know if you wanted to take just a couple of minutes and talk about the vaping project that you have started to work on.
Everyone, yes, so as Hillary mentioned, new to the team here, and in collaboration with Barbara Farnsworth, we are working on creating kind of a resource guide, best practices guide for schools, especially to be sharing some curriculum around vaping with students and parents in the area. So we've also connected with, I see Mima on here, some other groups in the area who are doing some great work in the same kind of arena. We're kind of in the assessment phase right now, but looking forward to having some more resources to share widely soon.
Great. Thank you, Maggie. And so updates from me primarily are things that have been mentioned. Was going to mention the vaping thing that Andrea talked about with our 2 of our local PDs being willing to continue to collect vape devices in their 24-hour medication drop box. And then as Hannah mentioned, Getting to Why. So we are really hoping that we will have youth risk behavior survey data in January of 2023. As a reminder, this was a survey that students took in October of 2021. So this is kind of typical for the time frame for us getting YRBS data, but we're really hopeful that we'll have it early in the new year, that we can be able to not only do Getting to Why, but this is also an opportunity for us to go into the community and into schools and present the school's YRBS data to parents, to school board, to really talk about what students are saying. And this is really going to be the first data set from youth coming out of COVID-19. So we're excited to see really what the effects of COVID-19 are going to show us within this survey. We have a lot of anecdotal data that we've collected from talking to partners, the increase in mental health crises, some increase in substance misuse among youth. So we're interested to see what the data is going to show. As a reminder, our community survey is still open. That goes until the end of this month. So we'll send out another link. It's been in our newsletter. We've emailed it out, but we'll send it out again in the minutes, and then it'll be in our newsletter again, but just would love help from our partners to broadly share the community survey. And that gives us sort of the adult perspective. So when we put the community survey together, the questions that we use on that survey are similar to the questions that are asked on the YRBS, because we want to hear what youth are self-reporting and then what adults are reporting on youth in the region. So we can look, we can't compare apples to apples, but it does give us a sense of, okay, here are what adults and caregivers are saying in the region compared to what our youth in our region are self-reporting. So would love anyone and all of your help to help spread that community survey out. So the next thing on our agenda, the last meeting in September, we dedicated the entirety of the meeting to talking about altogether sustainability. So we are currently in year 9 of DFC funding. So we will finish out this year at the end of September in 2023, and then year 10 will follow, and then DFC funding will be complete. So we wanted to really start now to have some conversations around what does sustainability for Altogether look like. So the last meeting, we had Kelly Keck from Epiphany Community Services, which is our evaluation team that we consult with. They come in and they help us with a number of things, but she came in and facilitated a conversation specifically around sustainability to try to understand from our coalition members, what are those things that Altogether does well that we want to talk about sustaining. And so thank you to everyone who participated in that. We are still having some follow-up conversations with some partners who weren't able to attend that meeting. But what we want to do is give an opportunity to share the things that were brought up and then give you a sense of, are these things funded by DFC and at what percent? So I'm going to share my screen and share a slide. Don't rat me out that I'm using Google on my DH laptop, everybody. So, can everyone see the Google sheet? Give me some nods. Okay, see some nods. Okay, perfect. Thank you. So, you will see this is broken out in a couple of different ways. So you can see at the top time and then money for physical things. So we took out what was brought up in the conversation at our last meeting and put them, we had to bulk some things together. And so that's where you see the notes section. So wanted to pull out, so there's paid staff time for both the DFC funding and then also the Regional Public Health Network. So that's the time for Andrea, Lauren, and now Hannah. Those are our 3 staff members who are part of the RPHN. So you can see currently, and I'm the only DFC, I am the only paid DFC staff member. So when you see a DFC time, it's talking about me. So my time is split funded by DFC funding, which is the federal funding from the CDC, and then DH match. So this is a shift in how my time is paid. Dartmouth Hitchcock recognized that we needed to start having some sustainability conversations about what Altogether is going to look like. And so they moved some of my salary into operational dollars as a way to figure out how do we sustain some of the stuff that Altogether does. And so my time includes sharing information, these partner meetings, data sharing, both youth mental health first aid, and the Connect. I'm a Connect post-intervention trainer. And so then you'll see the RPHN staff time. This is, again, Andrea, Lauren, and Hannah. And this includes things like the newsletter creation. That was the thing that was brought up as an item that our coalition members really see as being a success for Altogether. Information sharing, Take Back Day logistics. So Andrea manages all of the Take Back Day logistics, working with our PDs to get them signed up to be Take Back Day, to participate in Take Back Day. the all-together officers meetings, some data sharing, and then some of the trainings that Andrea and Lauren do, such as Connect, Narcan trainings, youth mental health first aid. And then Lauren does our website edits, so our all-together website edits. So then down below is the money for these physical things. So we talked about the community survey. That is, as you can see, 100% funded by DFC. That includes the creation of the survey, the evaluation, and the marketing. So some of that is with Epiphany Community Services. We have a contract with Epiphany Community Services to help us create the survey, and then they compile all of the results and present us with a report from the survey. And then we take care of the marketing on our side, but again, it is all DFC funded. The website, this includes the web maintenance. So we have a web designer. So we consult with a web designer if we need to make big changes to our website. So if you remember, our website just went through a complete overhaul about a year ago. And so that web designer has stayed on board to help us do some general maintenance and updates that we can't do as sort of our basic Lauren's basic web knowledge of making some simple text edits. As well as paying for the domain to have our uvaltogether.org site. Operation Parent Handbooks. This is something that we have money in DFC for, but Andrea also has in Sober Truth grants. So Sober Truth is a supplemental grant for DFC. Our understanding is that Sober Truth is a 4-year grant. We will be going into year 4 in May of 2023. Our understanding is that we do not need to have a current DFC grant to have a Sober Truth grant. So if we wanted to reapply for another 4 years of Sober Truth, we could do that even if we don't have a current DFC. That is our understanding. So as of right now, we are paying for purchasing of these Operation Parent Handbooks through both grants, DFC and Sober Truth. So then you get down to social hosting is really a marketing campaign, an ad campaign that we do around the holidays and then again around prom and graduation season. So this includes radio, PSAs, and social media. We create the graphics in-house and then we partner with Bob to do some radio PSAs and then we pay to do some social media advertising. Getting to Why, which we've talked about now a couple of times, this is a brand new program. We wrote this program into year 9 of DFC knowing that we wanted to do this in our communities. It's not something that we've been able to do in the past, but we recognize the importance of it. So really wanted to make sure that we used DFC dollars while we had them to write in this program. We are going into a 2-year contract with Up for Learning, which is the organization that facilitates the Getting to Why program. So they will be coming in and doing a training, an in-person training with our 4 schools, and then we'll be providing some TA along the way. And then there is a smaller cost for a year 2 implementation of Getting to Why. It doesn't include as much, it's not as big of a lift on year 2 because our schools will have already gone through year 1. The annual CADCA membership fee, this gives us access to a ton of trainings, information. We get notified of trainings all the time that we get to go and learn about different things in substance misuse prevention. This also allows us to attend some trainings in person because we're a member, or we don't have to pay for a registration fee for the training because we're already a CADCA member. Take Back Day marketing. So like I said, Andrea's position really does all of the logistics, but DFC has been used to do all of the marketing. So all of the radio PSAs, and as you heard Andrea say in her updates, people who came to Hannaford mentioned that they had heard about it on the radio. So that was all funded by DFC marketing dollars, as well as doing some social media advertising. Getting to Why materials. So this is things like we're looking at getting some tchotchke things that we can give out to the students for participating in Getting to Why. We can't use DFC dollars to purchase any food. So anytime we purchase food, looking at either the Dartmouth Hitchcock match or just taking out of operational dollars to pay for that because we can't use any of our grant money for food. And then lock boxes. We do on occasion have the chance to get lock boxes from Injury Prevention Center. And sometimes we share our lock boxes with Injury Prevention Center, but we do typically purchase, I think in our budget this year, we have money to purchase 75 lock boxes. So we do purchase lock boxes, and as Andrea said, we're giving them out. We used to give out more as we were tabling at more events. So I anticipate we'll be getting those out as we start to attend more things. But these are the things that were brought up and mentioned as things worth sustaining, things that we currently do, that we're doing well, that our coalition members wanted to make sure that we had a discussion on how to sustain these things. Does this Google Sheet make sense? Does anyone have questions? I can't see anybody's faces, so just come off of mute if you have a question. What are initial thoughts when you look at this and see the percentage of things that are currently funded by DFC?
We need a lot of sustainability.
Mm-hmm. Anyone else? So our next step in this process is if anyone on our coalition, if no one has anything like, oh, we're missing this, we need to add this to this list, or okay, now that I see how this is broken out, maybe we don't need to think about this as being sort of a top priority for sustainability. So that's sort of where we're at. So if anyone has anything they want to add, or if there's something on here that you're like, oh, well, I don't think that's a make or break. Like if we lose that, it's not going to change what we're able to provide to the community. Anyone seeing any of those things, or all of these things that are listed, things that we want to make sure we're having a conversation about sustaining?
Hillary, it's Peter. Is there any BDAS funding in here at all?
BDAS would be through the RPHN, so that would be an Andrea and Lauren and Hannah's side of things.
So Peter, we didn't want to super complicate things. So we do have a little bit of a budget, from BDAS to cover things like marketing and stuff, but it certainly is not anywhere near what we have available from DFC. So yeah, there is a little bit of BDAS funding, but it mostly covers the salaries of staff at this point.
Any other thoughts from folks?
Hillary, what I see there all makes sense to me, so I don't have any questions about that.
Good.
But as far as sustainability goes, these are percentages of funds that are spent. What's the hard number for sustainability based on the things that we spend money on and the support we get from DH? This doesn't really tell me that, so
Yep.
maybe we're a little afraid to find out. But what does that look like?
Sure. I am pulling up the DFC budget. So if you want to call out an item that you're curious about, Bob, that's listed on here, I am happy to tell you what the dollar amount is that correlates with that item. So are you thinking about radio? Like how much do we have budgeted for marketing?
No, not at all. Actually, what I'm thinking about is as this grant ends, and based on what the supports that you're getting, I correct me if I'm wrong, but each grant was something like $500,000 to $600,000, and so much per year for every year for the 5 years, correct?
So we total requested in year 9, our total federal request was $101,035.
Okay, so from a sustainability standpoint, in terms of solving that equation moving forward, I'm pretty sure we've talked about the fact that it's like we cannot apply for another grant like this, correct?
There's I think the opportunity to apply for some post DFC funding, but we have not looked into what that would consist of at this point.
Okay, so since I wasn't part of that conversation and you and I had talked on a side Zoomer, if there is such a word, is there like a number that you folks have come up with to say, okay, well, we need a 5-year commitment from some sort of institution to make this sustainable, or a 2-year commitment, or what does that look like?
We haven't yet. What our hope was that we wanted to get to this point where we have this list,
Mhm.
and then now that we have this list, we can see based off of our conversations with our coalition members, if you all think that these things are the things that are worth sustaining, then we can add the actual dollar amount to these things to give us an idea of what actual amount we are looking at sustaining. So
Okay.
for example, if we don't feel like Operation Parent Handbooks is something that we want to, like, if we're thinking about cutting some things, knowing that there's money in the Sober Truth budget for purchasing of these Operation Parent Handbooks, which we still have some in our supply closet, they're not super hot commodities. But if that's something we want to take out, then we're looking at cutting some of our supply dollars. So that's where we're at in this process, is like, is there anything on here worth getting rid of before we start totaling up what all of this costs to come up with that number that's worth sustaining? Does that make sense?
It absolutely does. It's kind of an inverse approach in my mind. Like, I know when we do our budgets, we have a list of things that we pay for, whether it's, for royalties for playing music or whatever it might be. But and usually we see a number attached to it. So, we can see the relative importance, but we don't necessarily see the relative cost. So when you look at that and go, well, maybe we could get by with that, but we don't know how much it costs. But we say, well, we maybe we couldn't get by with that. And then we say, well, that really does cost us a lot of money. So that, in my mind, would be a trigger to say, okay, well, we could live without that because it's not as productive on the end game, based on dollars spent for results produced or outreach or whatever we might be doing. So it's a little weird, at least in my mind, to look at an item, not knowing what each one breaks out at, and say to myself, okay, well, I like all the things that are there, but I'm also saying, okay, if I'm looking at it just saying, okay, well, we don't need that anymore because they tore the building down or something like that, then it goes from 100% to a 0%. But if it's something that I can't really place a value on, then I'm going, okay, then some manager someplace has to make a judgment call about that. So it just makes me wonder, how to evaluate things that we funded 100%, where I don't necessarily see what we're expensing in order to do that. Does that make sense?
Yes, that makes total sense. And I think when we were going through this process internally, we didn't want to confuse you all because there is so much crossover between what DFC pays for and what the RPHN, what is in the RPHN budget. And we were just trying to keep it as clean as possible because there is so much overlap in how things are funded and how the work is done, that this seemed like the cleanest way. Yes, Peter.
Okay.
Well, I'm just saying, there's overlap also in the sort of the kind of activities. For example, a number of these things have to do with education, and they're targeted at youth, at adolescents. And I'm just wondering, if you look at sustainability and you go to organizations like the Couch Foundation, for example, which is really looking at stuff related to kids. If you can bunch some of the items here and say these are all targeted to kids, then maybe that's part of the pitch, is to organizations like that.
Yep, totally. And there's some things that we've put in, you know, for example, youth mental health first aid. We put a good chunk of money in the year 9 budget for youth mental health first aid because we weren't sure what UNH Cooperative Extension's grant was going to look like, and they got their grant extended. So we probably won't be tapping into that money for year 9 because we don't need to. Because UNH's grant got extended, so they're going to pay for the materials, they're going to pay for the seat, for the online seat for individuals to go through that training. So we budgeted dollars for that, but we're probably not going to need to tap into that. That also means that we have the ability to potentially bulk order some supplies. So if we know we're going to need, you know, 75 lock boxes every year, maybe we bulk order some lock boxes before DFC runs out, knowing that we have a little bit of wiggle room in our current budget. So there are things that we have budgeted for that we're probably not going to use because there are already other funding options for those items. So this is where we're at. So what we will do is put a dollar amount to these things so that way we can see what this is going to look like for sustainability. And then I think you're right, Peter. It's having the conversation of, are these things youth related that we could look at applying for some private foundation dollars to help purchase for some of these items, or is it, you know, things that we could go after for some more donation type things? It's hard when we get into, you know, like a membership fee. People are not going to necessarily fund a membership fee, but those are then things that we can go back to Dartmouth Health and say, here's what this costs for us to continue to be a member of CADCA. This is the reason why we need to continue that membership. Is Dartmouth Health able to contribute out of operational dollars for us to continue to have a CADCA membership? But just remember, like, we're in year 9 right now, so we're having this conversation to give us enough time to find these answers before we are out of DFC funding.
Yeah, that makes perfect sense to me. And knowing, you know, some things about Couch and Dorothy,
Byrne.
help me out here.
Dorothy
Yeah,
Byrne.
Dorothy Byrne and also the Mascoma Foundation. Some of the cycles on that are pretty far out in terms of when they award different things. There's timetables for that. So if there's, you know, like Peter said, if there's a grouping, you know, kind of just organically 3 or 4 different areas that could be, you know, collated together to present to, you know, Dorothy Byrne about, you know, specifically helping children or teenagers, getting into that award cycle would be, you know, timely. And you know, knowing how they distribute things, I would think that would be a very, very appealing for them.
Does anyone have questions or curious about the actual cost of anything that you saw up there?
What do other organizations that have had the grant, and then when the grant stops, what have they done?
So I'm a part of bi-monthly meetings with other DFCs in the state. And there are a couple, so I believe the post DFC is called the CARA grant. So some have applied for post DFC funding, again, through the CDC. Others, and I think this is what makes us so unique, other DFCs are part of municipalities. So, or they're already an existing organization like a Boys and Girls Club. So they were already doing the work. They already had a staff, and then they applied for DFC so that they could do other things. Whereas we applied for DFC and then created the things that we were doing. Other people were already doing the things. DFC just gave them the opportunity to sort of enhance what they were already doing or to do a little bit more. There are a number of DFCs who have gotten other funding from, you know, other CDC pots of money through post DFC award opportunities, or are, you know, getting some private funding for some private foundations, or they just have found operationally ways to continue their work already within their institution. Any other questions? So the plan will be at our January meeting to lay out, like, this is what we're looking at in regards to sustainability for all together, to have some more concrete answers of this is what it's going to cost. Here are some potential opportunities that maybe we think about for some future funding or what that's going to look like. But the hope will be at our January meeting that we can have another conversation about sustainability and have hopefully a plan in place that can be adjusted as needed. But it would be great to go into the second half of our year 9 funding with a more concrete plan. Great. Well, thank you all. That was the last thing on our agenda. I am going to put in the meeting evaluation link, and I will send that out with the minutes as well. But thank you all so much. I think this has been our best attended All Together Partners meeting in a very long time. So it's really nice to see all of your faces and really appreciate you all taking the time to be here. And I hope everyone has a safe and happy Thanksgiving with their families, and stay safe out on the roads today. And we will see you all in January.